This program will provide an in-depth look at percutaneous endoscopic gastrostomy, PEG. This technique represents a critical component in the care of patients requiring enteral feedings. The program is divided into sections: patient selection, pre-procedure care, procedural techniques, and care of the patient with a PEG tube. Commentary is provided by clinicians at the Medical University of South Carolina, including Dr. Mark DeLegge, Director, Section of Nutrition, Digestive Disease Center, along with Phyllis Malpas, RN, Gerald Chiapponi, RN, and Gregory Buck, PAC. Patients with a wide variety of conditions may be candidates for PEG tube placement. In general, this intervention may be considered for an adult, a child, or an infant who is unable to eat.
A patient who should receive a PEG tube is someone who's going to need some enteral feeding, meaning feeding through the digestive system, for at least 2 weeks. And these are patients who either cannot or will not swallow.
In adults, probably the primary patients you see with difficulty swallowing are patients who have undergone a neurological problem, such as a cerebrovascular accident, a CVA, and also you'll see it in patients who have dementia, and it could be Alzheimer's or non-Alzheimer's dementia. Many times in younger patients, you might see patients who have had esophageal tumors and are maybe preparing to have radiation therapy and are currently unable to swallow. You can also see it in patients who have other neurological impairments like multiple sclerosis that actually affects the ability of the esophagus to pass food from the mouth to the stomach. In children, it's different scenarios. Sometimes it's a case of some type of genetic impairment. It could be an oral problem like cleft palate, cleft lip. Sometimes it's just early neonates and children who have failure to thrive.
PEG tube placement is contraindicated in patients who are receiving anticoagulants or have an obstruction of the esophagus, which may prevent the introduction or removal of the tube. The inability to clearly identify a safe percutaneous entry site also precludes PEG tube placement. Finally, a PEG procedure is contraindicated in patients who have had multiple surgical procedures near the gastrostomy site, or those who have medical conditions that would put them at high risk during the procedure.
Consent is very important. Also walking them through the issues about the possible complications from PEG tube placement, whether it's bleeding or causing infection in the gastric wall or perhaps in the peritoneal cavity, or even having some respiratory problems with the procedure from the anesthesia, and walking them through those to let them know that there are some complications, although they're relatively rare. On the day of their PEG tube procedure, the patients maintain MPO. And I do use pre-procedural antibiotics. I think there's some controversy regarding this, whether you need to use pre-procedural antibiotics. But when you look at the preponderance of evidence regarding this, it seems to be relatively clear that using pre-procedural antibiotics does prevent post-procedural complications, especially wound infection.
Percutaneous endoscopic gastrostomy provides direct access to the stomach for placement of a feeding tube. PEG tubes are inserted using a method that utilizes the visualization capabilities of endoscopy to provide the patient with the advantages of less invasive percutaneous access. PEG tubes are placed into the stomach. A J tube can also be placed through the PEG tube to deliver nutrients directly into the jejunum. PEG tubes are available in a variety of designs. Some are used to establish the initial access for feeding. Others are designed to replace that initial tube. PEG tubes also come in a range of French sizes.
If I'm trying to pick a device, frequently if I have someone who needs a PEG tube placement where I feel they aren't going to require a J tube anytime in the future, I use a 20 French tube. And if I have somebody who I feel is going to require some jejunal feeding or a PEGJ, I'll jump to a 24 French tube.
All PEG tubes have internal bolsters to keep them from falling out and external bolsters to keep them from migrating inward. For an initial placement PEG, the internal bolster is typically a dome or mushroom-shaped structure attached to the distal end of the PEG. A replacement peg has two different options for the internal bolster. The first option is the solid design, the same type as found with an initial placement peg. The second option is the balloon-type bolster. The solid internal bolster is used for initial placement pegs since it is generally very secure, requiring vigorous pulling for removal. This allows for formation of a well-healed stoma. This type of bolster also provides an advantage with combative or demented patients who may become confused and attempt to pull the peg out. The balloon-type internal bolster is the option most often seen with replacement pegs. The balloon-type bolster is generally less durable than the solid bolster. However, due to its inflatable-deflatable design, it is intended to be more easily removed when necessary. The external section of PEG tubes also comes in two options. With the first option, the tube extends out from the patient. The second design is referred to as low profile because the entry port for the PEG is integral to the external bolster and is therefore very near skin level. The low profile device chosen must be long enough to allow positioning of the internal and external bolster without creating tension on the tract. The original PEG tube design makes the feeding process easier for nurses and caregivers as it allows more of the tube to be grasped, making syringe or feeding tube attachment easier. The low-profile design is much less obtrusive to the patient, making it a popular option for alert patients, particularly those who lead active lives. However, these devices require attachment of specific adapters to enable administration of feedings, and this may be difficult for some patients. There are also systems available which allow placement of the low-profile device at initial PEG tube insertion. This avoids the necessity of having the patient return after initial tract formation for removal of the PEG tube and placement of a low-profile device. The initial placement pegs are supplied in sterile kits that contain the necessary accessories for placement. These kits may be supplied as a single bag, single tray, or two-tier tray system. Two-tier tray systems are preferred since they organize the equipment in a way that increases the efficiency of the procedure. The top tier contains items required to prepare for PEG tube placement and finish the procedure. The second tier contains the PEG tube itself as well as the devices needed to place it. There are two techniques for initial PEG tube placement: pull and guide wire. The guide wire technique is also known as the push technique. Kits are available for each and are labeled with that information, along with the French size of the tube and a use before date. Dr. Delegui will demonstrate the pull technique for PEG. To start the procedure, the patient is positioned supine with the head elevated and appropriate conscious sedation is established. Oxygen may be provided via nasal cannula and the oxygen saturation levels are monitored by pulse oximetry. The posterior pharynx is anesthetized and a bite block is positioned in the mouth. Particular attention is paid to posterior pharyngeal suctioning. These preliminary aspects of the PEG procedure relating to patient positioning, oxygenation, and suctioning are critical. The endoscope is advanced and the esophagus, stomach, and proximal small intestine are examined. The endoscope is then pulled back into the stomach and the stomach is insufflated.
Insufflation during PEG tube placement is critical, and this is done by air passed through the endoscope. Without insufflation, you can't see anything. By insufflating the stomach, you actually move the stomach up towards the abdominal wall so that the distance that you actually have to penetrate the needle through the abdominal wall into the stomach is shorter. So good insufflation is critical to an adequate PEG tube procedure.
The light from the endoscope is directed at the abdominal wall. With the lights in the room dimmed, a translumination effect is seen, generally in the left upper quadrant of the patient's abdomen. At the point where the translumination is most clear, finger pressure is applied. The indentation of the gastric wall produced by palpation is noted endoscopically, and the site is marked. The site is then prepped using standard technique. A snare is advanced through the biopsy channel of the endoscope and positioned at the proposed entry site. After a sterile prep of the site is completed, local anesthesia is administered. The needle is then advanced through the gastric wall while pulling back slightly on the syringe plunger. Safe site selection is confirmed when endoscopic visualization of needle tip entry into the stomach corresponds with air entry into the syringe. A 1 to 1.5 centimeter incision is made at the entry site. This incision must be sized to accommodate the diameter of the PEG tube that is to be inserted.
From my perspective, it is better to have too large a wound than too small a wound. If you make too small a PEG tube cut, then as you pull the dilator in the PEG tube through the abdominal wall, the tissue around the PEG is compromised. It's tight. There's lack of blood flow, and I think that leads to PEG tube leakage and wound infections. So I generally like to see my incisions be somewhere around 1 to 1.5 centimeters.
The needle cannula assembly is inserted through the incision into the stomach under direct endoscopic visualization. The snare is closed around the cannula and the needle is removed. The looped insertion wire is passed through the cannula into the stomach. The snare is loosened from the cannula and tightened around the wire. The wire, snare, and endoscope are removed together from the patient, and the wire is removed from the snare and scope. The insertion wire exiting the patient's mouth is attached to the tapered dilating segment of the PEG tube. This is accomplished by inserting the big loop of the insertion wire through the little loop on the PEG tube. The PEG tube is then threaded through the big loop, internal bolster end first, and pulled to tighten in place. The tube is lubricated, and the insertion wire segment at the abdominal wall is continuously pulled until first the dilating segment and then the PEG tube itself exits the incision. The tube is pulled until the internal bolster seats snugly against the gastric mucosa. The insertion wire is cut, and the external bolster is advanced over the PEG tube to a point approximately 1 to 2 centimeters from the abdominal wall. The PEG tube is cut to a comfortable length for the patient. The external Y adapter for feeding is plugged into the open end of the tube. The larger arm is the port for the formula, and the smaller arm is the port for administration of medications. The caps on both ports should remain closed, except while in use. The endoscope is reinserted to confirm proper positioning of the internal bolster against the gastric wall. The external bolster is adjusted as necessary so that proper tension is achieved. A sterile dressing is applied to the abdominal entry site. 24 hours after the PEG procedure is complete, the tube can be utilized for feeding. The push technique for PEG utilizes a guide wire rather than a looped insertion wire. In a manner identical to the pull technique, the guide wire is inserted through the cannula and grasped by the snare. The endoscope, snare, and guide wire are pulled out of the patient's mouth, and the guide wire is removed from the snare and scope. While tension is maintained at both ends of the guide wire, the PEG tube is pushed over the guide wire through the oral cavity, esophagus, stomach, and abdominal wall. In preparation for feeding the patient, proper hand washing should be completed. Before the formula is administered, the patient should be in a sitting position or have the head of the bed elevated at least 30 degrees. Then, proper tube placement must be confirmed. To do this, 5 to 10 milliliters of water should be drawn into a syringe. If the patient is a child, 3 to 5 milliliters of water should be used. The cap on the larger port of the PEG tube is opened, and the syringe is attached to the port. A stethoscope is positioned on the left side of the abdomen just above the waist, and the water is injected while auscultating for a bubbling or gushing sound. Hearing that sound during the assessment process is an important indicator that the tube is in proper position. If no sound is heard, injection is repeated. If no bubbling is heard after this repeated attempt, the feeding should be withheld and the physician notified. After the bubbling sound is heard, stomach contents should be gently aspirated into the syringe to check the amount of residual. The amount of residual is compared to the guidelines set by the physician. If the amount conforms to the guidelines, it is re-injected and the tubing flushed with water. The feeding can then be administered. If the residual amount is too high, it should be re-injected and rechecked 30 to 60 minutes later. If it remains too high, it is again re-injected and the physician notified. However, if it is within guidelines, the patient can receive their feeding. The flow of formula during a PEG tube feeding is regulated according to physician guidelines. It can be delivered via a bolus method using a syringe, or by a continuous method which utilizes a pump. Bolus feeding allows for delivery of formula over a short period of time. The technique will vary depending upon the PEG device that the patient has in place. If the patient has a standard PEG tube, a gravity feeding method may be used. The syringe is connected to the end of the tube and formula allowed to flow in by gravity. Adjusting the height of the syringe alters the rate of flow. After the feeding is complete, the tube is flushed with water to maintain patency. If the patient has a low-profile button PEG, the anti-reflux valve in the device will prevent formula flow by gravity. Rather, the formula must be injected. To accomplish this, a bolus feeding adapter is connected to the device by stabilizing the button with both tabs and inserting the adapter. With some button pegs, the adapter must be turned to secure it to the button. A syringe can then be connected to the adapter tubing and water injected to assess patency of the button. Formula is then injected using the syringe. At the end of the feeding, the tubing is flushed with water to maintain patency of the device. The bolus method is also used for injection of medications through the smaller port on the PEG tube. Continuous feeding requires use of a feeding pump. After the tubing is attached to the pump is turned on and regulated to allow the formula to flow at the prescribed rate. The amount of water the patient should receive with the tube feeding is also prescribed by the physician. This can be delivered via the bolus method with the syringe or through the pump. Water delivery will both provide hydration for the patient and prevent clogging of the tube. With either bolus or continuous feeding, it is important to deliver the formula slowly to prevent the patient from developing stomach cramping, nausea, vomiting with the potential for aspiration, gastric bloating, or diarrhea. Patients, too, will often identify other specific measures which prevent problems. For patients who are immobile, after the feeding is complete, the head of the bed should remain elevated for at least 30 minutes. Whether a patient is using a syringe or pump for feeding, the equipment must be properly cared for.
After they return home, we ask them to rinse the feeding equipment after every feeding, and if they need to, they can wash it with warm, soapy water, but be sure that they rinse it thoroughly and dry it and keep it in a safe, dry place.
Mouth care is very important for the PEG patients. I think sometimes we forget that because we're feeding them through an alternate source, that Mother Nature's natural route is neglected. Mouth care is very important, and that usually consists of if a patient is able to brush their teeth, good oral care, and lip balms to moisten the lips to keep them from cracking.
The stoma, or skin entry site for the PEG tube, should be cleaned daily. Initially, hydrogen peroxide on a cotton swab or small piece of gauze may be used to clean around the site. During the cleaning process, the tube should also be rotated to ensure that it moves easily in a full circle. If it does not, the physician should be notified. As part of stoma care, the site should be assessed for redness, pain, or soreness, swelling, or drainage. If any of these are noted, the physician should be notified. A dressing is then reapplied with the drain sponges positioned over the external bolster. After a few days of healing, the site can be cleaned with mild soap and water and left open to air. There are various methods of securing the PEG tube. Stabilizing it to the abdomen with tape is often used initially, although patients may use a variety of other methods. When the PEG tube is placed, a notation is made of the tube mark closest to the external bolster. When stoma care is being performed, the position of the external bolster should also be checked using the markers. The bolster should be 1 to 2 centimeters away from the abdominal wall, allowing the free float of the tube that will avoid excessive pressure at the site. Checking the tube markings will also indicate whether the tube position has changed due to migration of the tube inward or outward. Decompression of the stomach may be ordered by the physician before or after feedings for the purpose of removing air. To decompress the stomach, the cap on the PEG tube feeding port should be opened. Then a decompression tube is attached to the PEG tube and the stomach is allowed to drain as prescribed. While caring for a patient with a PEG, there are some problems that may be encountered. This section will discuss management of nausea and vomiting and the potential complication of aspiration, constipation and diarrhea, leakage around the tube, and backup of gastric contents into the tube.
If the patient has a tendency to develop nausea and vomiting, that would be one of the scenarios where you would ask the patient to potentially move maybe from a bolus feeding to move to a continuous feeding over several hours. Sometimes it's the quantity of the feeding that may be causing them to be nauseated. They might try different types of feeding products. They might try something that's diluted with water, a little more water, and kind of troubleshoot what could be causing the nausea. You may want to make sure that the feeding substance is at room temperature and is comfortable for it to be placed into the stomach. You'd be very careful to check your residuals because it could be that the patient's unable to process the food from the stomach into the duodenum. If the patient does develop nausea and vomiting and has a risk for aspiration, you would definitely want to keep the patient upright and get them into a physician or to an emergency room very quickly because you are at risk of aspirating if the patient can't swallow and is still bringing up some type of feeding. And you would also, of course, want to stop the feeding at that time and determine what the cause of the vomiting is.
Constipation and diarrhea can indicate a need to change the formula, the feeding schedule, or both. It could also be related to another problem, so a complete assessment should be done.
Constipation, or the opposite, diarrhea, can be a complication of tube feedings. It's very important for the patient in the home setting to contact their physician and let them know right away. Of course, we don't want these patients to become dehydrated through chronic diarrhea, nor do we want them to be obstructed from chronic constipation. So again, it's very important for them to immediately inform their physician of their particular situation.
Leakage around the tube or button can occur. This may be due to improper patient positioning during feeding. Keeping the patient upright during and after the feeding may resolve this problem. Leakage around the tube may also result if the tract enlarges. This may be prevented by proper stabilization of the tube without tension. If the patient gains weight, the external bolster may need to be repositioned. If the tube has a balloon, increasing the amount of water in the balloon may also help stop leakage. A decrease in gastrointestinal tract function or a feeding rate that is too rapid can cause leakage around the tube. An assessment of residuals will reveal if that may be the cause of the leakage. If residuals are high, decompression, a change from bolus to continuous feeding, or a decrease in feeding rate may prevent further leakage. The cause of leakage around the tube must be determined and corrected to avoid skin irritation. To maintain a healthy stoma site, the skin must be kept clean, dry, and free of drainage. To protect the skin from drainage, a waterproof barrier around the site may be used. High residuals may cause a backup of gastric contents through the tube. This may also be caused by a failure to properly close the ports on the tubing. Again, residuals should be monitored and all connections within the system checked for security.
As a gastroenterologist or as an endoscopist, many of us feel that once you put your PEG tube in place, that your job's done. And in fact, your job's just beginning. As I explained to my colleagues, the PEG tube placement is the longest implant that an endoscopist puts in a patient. So the whole team plays a very, very big role here.
Particularly in a patient with a PEG, in the endoscopy role is expanded from a nursing perspective because you may have a connection with the patient before and during and after the procedure, and you want to have them educated throughout the whole time. So in the PEG scenario, you have the physician involved, the patient involved, the family involved, nursing involved, as well as nutrition and dietary, and then leading on to a home health care scenario. So it's a true collaborative effort because as opposed to other endoscopy procedures where the patient has the procedure and they have no outer external sequela, here in this case you have a patient who has some device who needs to take care of it in the future. So it's very important to have all of those pieces working together: nurses, physicians, nutritionists, and of course, most importantly, the patient and their family.
The care of the patient with a PEG tube at Medical University of South Carolina provides an example of how endoscopic care can vastly improve the quality of life for the patient. We hope that this program has provided you with an in-depth understanding of percutaneous endoscopic gastrostomy, from history of development, through placement techniques, to care of the patient with a PEG. For further information, please contact your Boston Scientific Microvasive Endoscopy Territory Manager.